So let's start with gynae history taking. So this is from Geeky Medics, and it's a good checklist in general, maybe a bit wordy for us as GP trainees, but early on they talk about wanting to confirm the last menstrual period, gravity, and parity of the patient. Often this is information that might already be given to the candidate, but maybe not period, because that's usually something that needs to be explored in greater detail, but the other two bits of information might be. Apart from this bit relates to the Socrates side of stuff, so mainly related to pain, of course, as we know. But this next bit is quite important, screening for other key gynecological symptoms. So all of these questions are usually very relevant to ask about in gynae history. Abdo pain, pelvic pain, postcoital bleeding, intermenstrual bleeding, postmenopausal bleeding, abnormal vaginal discharge, dyspareunia. Now that can be both deep or superficial, and there are different differentials based on that, but asking just about pain during sex is usually enough. Any skin changes around the vulva, any itching, fatigue, fever, and weight loss. So don't forget those systemic questions that we want to ask about, particularly those last few ones that might be associated more with malignancy. While we're talking about malignancy, I'm going to ask a quick question. Is anyone not aware of LEGO C, the mnemonic that we use to remember the malignancies, the main malignancies associated with persistent thrombocytosis? Okay, if anyone doesn't know this, please put a comment in the chat, and I'll go through that because it's quite relevant, and again, something that isn't always talked about or known about. Again, they talk here about ICE. Interesting that here they've done the history, a lot of the history taking, and they bring in ICE at this point. Again, certainly with the RCA, I was recommending that everyone do it along those lines. And then summarizing might be a very good thing to do, not just to make sure you've got the right information, but also to tie up all your thoughts, to get all that information collectively. And, often I usually find that, the way we've learned cases, particularly if you're, went to medical school like me where you did problem-based learning, you think about cases and you think about narratives, and as you talk through or you say aloud a cluster of symptoms, then essentially you'll be able to piece together what you want to do and what management plan a bit easier. So it's sort of speaking into using your verbal skills and your cognitive and working memory in that moment in time to, again, bring in more thought processes, accessing your long-term memory, and enabling you to access as much information or as many cognitive processes as you can while you formulate the next step. And we all do this quite naturally, of course, but it's quite important when we do these things and we're cognizant of it. So we're paying attention to how we're doing it, how we're thinking about these things, how we're summarizing, and moving on to the next step. Because we are compartmentalizing these consultations, these 12-minute consultations, into sections. That's why we're talking about things. But how do we do that structurally? How do we stop missing things out? How do we use only relevant bits of information? How do we get the most of our patients and the time that we're allocated, right? Next, screening for relevant symptoms and other body symptoms. That's quite important as well. Here's a menstrual history, of course, for you to take. And again, the order of this is less important. It's more important that you get all of these things done. So contraception, reproductive plans, I thought that was a good one, particularly in a case where, a couple is struggling to get pregnant, for example, or there's something else of concern that the patient might have. Again, past gynae history, it's quite relevant. The cervical screening, that you confirm that, it's very, very important, as you can imagine. Unfortunately, our rates of cervical screening in the country has dropped, and the Jade Goody effect has been lost. If you're not sure what that is, Jade Goody was a contestant on Big Brother, quite a famous contestant, and unfortunately she developed cervical cancer and passed away at a very young age. And after that sort of hit the national news, cervical screening in this country went up very significantly and remained high for a number of years. But we're finding that Jade Goody effect has unfortunately diminishing over time. So it's even more relevant that we're asking these questions. And if we're picking up on EMIS or System 1 or whatever, that patient is overdue their cervical screening, prompting that patient or sending them an invite via AccuRx is quite relevant. Again, past medical history, obstetric history as well, drug history are quite straightforward things. But this is quite relevant. What do we ask for in family history in terms of if someone's coming with bleeding as an issue, or mainly bleeding really. So we ask about malignancy, bleeding disorders, and blood clots is another relevant bit. Again, asking about a history, a family history of VTE, so venous thromboembolism might be relevant as well for you to think about screening and all the rest of it. I thought this was really interesting and good in the social history. I'm not sure we will always get a chance to explore this, but it's very important to always bear in mind that you're taking a gynae history, you're taking a sexual history, and you should always be aware of domestic violence and domestic abuse. Ideally, we would all be talking to every single one of our patients. This is a bit of an opportunistic screening ability, if you will, to be able to say, do you have a regular partner? Do you feel safe? Have you had any concerns? Do you need to talk to anyone about anything else? Are you aware of all the services that we have? Something along those lines. And again, we have instincts as doctors where we can pick up on somebody being uncomfortable, someone not being quite happy in the way they're talking about things, maybe being a bit guarded, maybe certain areas of the history they don't want to elaborate on, and you pick up on that gut instincts where you feel that things aren't quite right, and maybe they're even presenting with their partner and you want to talk to them separately. Maybe it is someone who is still a minor under 18. So bear in mind all of these things that might be happening, and have a low threshold to want to explore this with your patient further, and be aware that safeguarding is really important. We have to keep our patients safe first. That is the priority, and then we do the medicine. But we can do things concurrently, and this is a very important aspect that we need to look at, particularly in this cohort of patients.